the real drivers of the HIV epidemic. And we're going to look at it today from several perspectives. Unfortunately, Rosemary Kumwenda of UNDP couldn't join us now, but maybe she'll come in later. But how are we going to address these structural barriers? And we're going to hear an overview from some UN colleagues, and then hear some of the practical approaches and interventions that people have come to put in place, both from the National AIDS Council perspective and also the community perspective. And then we're going to hear about collective community action, which really, as we all know, is at the heart of changing the trajectory of the epidemic, empowering communities so that people can be more enabled to live their lives free of stigma and discrimination, and address these very difficult barriers to access to services. So without further ado, perhaps I will now hand over to our first speaker, Simone Salem of UNAIDS, who's going to give one of the overviews on addressing legal and structural barriers to access to services for key populations. Simone, please take the floor.
Thank you, Tim. Thank you so much. I really am very happy to be with all of you here. This is my first community of practice meeting, and I'm really looking forward to this discussion. So I'm going to be giving a very quick overview of the legal and structural barriers we all know of and how they could be addressed to really impede less access of services to key population. Next slide, please. So the barriers continue, as we all know, to impede the KP's access. And like what you've said, Tim, they are all here, the stigma and discrimination, how we've seen it more and more interwoven with other forms of discriminations that's based on gender, race, occupation, if being a sex work, and so on. Of course, the hostile and often violent environment against key populations, what we've seen recently happening in some African countries in the last couple of months. Of course, the violating law enforcement and healthcare providers' habits and mechanisms that are not working. We have also the lack of access of information, like you said, to adolescent and young people's age of consent laws. The lack of tailored services for young key populations. Very important, and I've seen last week, I think UNESCO have been working with Positive Learning, and they have released a very interesting recommendations of how we could do more with young key populations and people living with HIV. The low funding, of course, of the programs to address societal enablers, and the scarcity of indigenous data, along with, of course, the lack of important resources, but as well as services addressing gender and gender-based violence. Next slide, please. So the criminalization is, again, what you've said, a major obstacle, and this is the data we have from the Global 2021 report. We still have 135 countries criminalizing, and it's really very, very serious, the HIV exposure, non-disclosure, and transmission. And we also see how criminalization has been impeding access to service, especially in the COVID response. The study in Southern and Eastern Africa among sex workers showed that there has been a very high level of violence from the police coinciding with the COVID response and the lockdown. Next slide, please. And just to mention that with this criminalization, apparently all the efforts that we all need to be working together to really address the overuse of these criminal laws. But opportunities and momentum are there, and I think this year has been catalytic, and if we are able to move the needle on the ground, it would be because of these incredible commitments we have, beginning with the political declaration on HIV and AIDS. And the political declaration 2021 is very different from the one on 2016. And one thing that I would want to highlight is, for example, the community-led interventions. 30% has been available in 2016 political declaration, versus in 2021 we have, it's composing of 30% for testing and treatment, 80% in prevention, and 60% for addressing societal enabler interventions. Quite a very stark change. The Global AIDS Strategy, again, 2021-2026, which really pushes us it renews and extremely gives room for anchoring the HIV response in more gender and human rights and equality principle. And the Human Council resolution on human rights and in the context of HIV. Next slide, please. When we speak of the societal the targets of the strategy and how these targets are, yes, the HIV service and the integration are quite important, but the evidence have also shown us that if we do not work on the societal enablers, it will be a big mistake. So the 10-10-10 targets are here, and for the first time, they are telling us what to do. So we need to be working to make sure that less than 10% of countries have punitive and legal laws. We have to make sure that less than 10% of people living with HIV are experiencing a stigma and discrimination, and less than 10% of women and girls living with HIV are subjected to gender-based violence. Next, please. This is a very powerful slide. I think it shows us how these societal enablers can save lives. And with this modeled predictions, it just tells us if we, again, if we work on the service targets without the societal enablers, we will definitely be, the human cost would be very high. And if we do work on the societal enablers, we will be able to avert in the end 2.5 million additional infections, 1.7 million additional AIDS-related deaths from 2020 to 2030. Next, please. So bringing it all together, if we look at some of the, I'm going to be speaking to some of the platforms that are there right now and could help us a lot in addressing some of these barriers we've been speaking of. On stigma and discrimination, which is really becoming one of the most important barriers that we can speak to, the Global Partnership for Action to Eliminate All Forms of Stigma and Discrimination is there, and it's growing in momentum. Many of the co-conveners of the Global Partnership are here with us. We have UNDP, we have a Global Fund, we have GNP+, UN Women, and UNFPA. Thank you, Tim, and excellent members from the Technical Working Group providing all the support to the Global Partnership. So the commitment so far has led to 29 countries joining. This slide, I would like to bring to light how we could work together with the Global Prevention, the Coalition on Prevention. What are the countries that are could be working together to synergize the actions? So this is one thing that we can call as recommendation after we finish the meeting. Next, please. So what do countries commit to and how we support or how we work? These are the objectives of the Global Partnership. It's basically translating these human rights commitments into country action. We do have action plans on the ground. It's how we all work together. Again, the partnership is extremely important, especially when we come to you to make sure that we use best the resources available, whether from Global Fund, PEPFAR, CDC, and other partners. How we generate and disseminate the evidence through the stigma index, through the gender assessments, legal environment assessments, and so forth. Again, what makes it different are three things I want to highlight here. First of all, it's the leadership of the community. It's led by the community, it was called for by the community, and therefore it's very important that they remain in the front line and central to the response. How the guidance on that work, we do know what works. So we do have guidances, we do have evidence, and we've put it together in a guidance on evidence-informed interventions that address stigma and discrimination in 6 settings. These are the settings that the Global Partnership asks countries to commit to. And we do also have a monitoring and evaluation guideline that will be launched early next year. So these guidances are really critical to move the needle on the ground. And of course, like I said, and the most important as well is the catalytic synergies and linkages, which we need to always keep in mind. Next slide, please.
If you can start to wrap up, Simone.
Sure. So these are the settings. I'm going to be, I'm leaving the slide. So next slide, please. Again, the advocacy. Again, I'll be sharing nice links in the chat. Next slide, please. So what works and need to be continued. The next 4 slides, I'm going to be going through them quickly as well, because law enforcement can take ages, yes, but we need to start somewhere. And with countries diverse, situations, environments, we have the conservative settings, but we have also the capacities on the ground of the communities and the partners, but we do have the commitments from the countries, the resources. So here is a list of what could be done and what we could pick and choose from. So the training, of course, capacity building, convening advocacy. Next slide, please. Please take time to read later the countries and the examples. Accountability of human rights violations, the creation of, for example, in Jamaica, the National Human Rights Institute. I'm sure many countries have models like that. Tracking cases of violence, the emergency support funds. Here, I want to say that we always react to these human rights crises, but we need to be working closely on a more of a proactive response to that. Advocacy based on data. Again, the research is quite important. Next slide, please. The guidance and quality assurance, what we make use of the integration in the integration of human rights and gender interventions in the Global Fund grants and PEPFAR COPs. The examples here are also telling the monitoring and evaluation tools and scorecards that are produced. Policy reforms to enable KP access to services. I could give the example of the Central African Republic, the adoption of the National Charter for Quality of Care, and how this has been monitored, the platform for reporting abuse, and the training for healthcare workers. Next, please. And this slide, which is last on the intervention, is the parliamentary process and strategic litigation towards law reform. We have the broad non-discrimination provision, as we've seen in Iran with the anti-discrimination bylaw, but also there is the population-specific provisions, as in Angola, Gabon, removing the provisions criminalizing same-sex relations. And again, I'm giving here examples of great work that has happened till date in the other countries. Next, please. So the guidance on fast track and human rights is extremely important if you want to move with the targeting the societal enabler targets in our interventions. We have to extremely be careful to make sure that all of this checklist is reflected in the service provision. When we do prevention services, we need to make use of this toolkit a lot. I'm not going to go again through them because of the time. Next slide, please. I'm leaving you with these additional tools that have been provided. Again, the evidence for eliminating the stigma and discrimination, the fast track human rights, but I want to also highlight the HIV and human rights fact sheets that have been developed this year on all key populations in all languages. And I leave you here. Thank you. I give the floor to my friend Fariba to speak to the people who use drugs and in prison settings. Thank you so much, Tim. Over to you, Fariba.
Thank you very much, Simone, and thank you very much, Tim. And for everyone on the call, good morning and good afternoon. Thank you for having us, UNODC, to also present our work here to you, actually. So my name is Fariba Soltani. I'm the chief of the HIV/AIDS section for UNODC, and I'm the global coordinator for HIV in UNODC. Next slide, please. So I just want to give you a very small overview of who we are and what we do. In this slide, you can see pictures of all the different work that we do at the country level. As you are aware, we are the convening agency within the UNAIDS family for addressing HIV amongst people who use drugs and also in prison settings. And as you see here, I mean, the importance for us is the presence at the field level. So we have a very small team based here in Vienna of only four staff, and the rest of our staff and the team is based at the country level, because this is where the advocacy and the work needs to happen. So next slide, please. So we work in 24 high priority countries where we focus our efforts for HIV amongst people who use drugs, and in 35 high priority countries for people in prisons, as you can see on the map. But no, we are getting more and more requests for working in other countries where we are currently maybe not so much involved. So this map is expanding because there is a more and more request for our participation and involvement. In the blue box, you see who we work with, and we work with ministries of justice, interior and health, national drug control agencies, national AIDS program, law enforcement agencies, prison administration, of course, our civil society organization and community partners, our UN partners and donors. Next one, please. And as Simone very nicely actually presented, we have new global commitments and new goals and targets that we have to reach, in addition to what we've had from before that we have been working on. So Simone went into a very detailed description of what are the commitments are under the new global AIDS strategy. We also have a new UNODC strategy with a strong focus on the work that is under our mandated areas for HIV. Of course, we have the on-gas outcome document of 2016, which forms the basis of our work, and it's the member states' commitments on how to address the world drug problem. And of course, we also work towards the United Nations Standard Minimum Rules for the treatment of prisoners, which are called the Nelson Mandela Rules, as well as the Bangkok Rules, which we don't have here, but it's for the treatment of women in prisons. So we have all these tools to work on. And in addition to these, next slide, please. We also have the United Nations Common Position on Incarceration, which actually was approved in April 2021, and also the Common Position on Drugs. And these are two tools that we are the custodians of, and we are leading on their implementation. And the UN Common Position on Drugs has already been distributed to all the country teams and through the UNRC system. And of course, the UN Common Position on Incarceration addresses how there is an overuse of incarceration for issues that you don't need to incarcerate people for. So I think they are very strong tools that we can all use, and I can send you the links to them both in the chat later on so that you have access to them. And it forms a very strong basis for what Tim was mentioning at the beginning about the criminalization of key population, how this is creating a lot of barriers and a lot of problems that makes the situation of HIV and COVID even worse for our key populations. Next slide, please. So we have also many guidances and tools that we have been working together, not on our own. This is not just UNODC. We have been working with our partners, especially with our civil society partners, working very much hand in hand to see what are the needs and developing guidance and tools that can be useful in the HIV responses at country level, and also with our UN partners. So these are, if you go on our website, I'm not going to go into details, but you can have access to this. Next slide, please. So yeah, we're one of the major part of our work is capacity building. And as I mentioned, we have very good tools. We have the I Do It, which was developed with input. We have the tool for addressing women who use drugs, which was developed hand in hand with Inwood and all our community partners, as well as the one for addressing HIV among people who use stimulant drugs, that I really have to thank Matt Southwell for really being a very strong leader in the development of this tool. We have the training packages for our law enforcement organization. And this is something that I really need to stress on. We need to scale up our work with our law enforcement partners, bring them meaningfully around the table to be a part of this discussion, because this is, I think, what is missing. And this is something that we're trying very hard to make sure that they are around the table, involved, and feel an ownership when we are developing our national AIDS strategy, national harm reduction strategies, and now the COVID response. And of course, building capacity in the prisons is one of our main streams of work. Next one, please. Advocacy. We can't stop stressing the importance of advocacy, even in countries where they're doing very strong harm reduction work. This can change overnight. So really, this is what I was saying, that the presence of our colleagues at country level to ensure that the advocacy work is done, to expand, and increase the access to opioid agonist therapy, in addition to all the elements of the comprehensive package, the needle syringe programs, access to ARVs. One thing that Simone mentioned in her presentation, I mean, the stigma, discrimination, and barriers to access to services is not just the law enforcement and the legal issues, but also healthcare providers. So the advocacy and the work with the different sectors is very, very important at country level. And these are just a couple of examples of where we have had very positive experience through our advocacy work. For example, Vietnam has approved a multi-dose dispensing of methadone and OAT by the Ministry of Justice in 2020. This is a big, big achievement, and it was done because of the COVID, but one of the positive outcomes of the COVID, if we can have a positive outcome. And Egypt and Pakistan, we have been working for years and years, and in 2020, they approved to start OAT program. And Kenya, Morocco, we are working on prisons, and lots of excellent achievements through the work in the prisons, including introduction of OAT in prisons. Next slide, please. I know it's my time is short, Tim. I'm wrapping up. I know it's you get next, please. Yes, so we're working on policy reform. I will share my slides. We have different country examples here. Next slide, please. And this I need to have a 1 minute to actually talk about is the work that we are doing, the partnership that we have, that we enjoy and we're very proud of to have with our civil society and community partners. We have two working civil society partner groups, one for drugs and HIV, one for prisons and HIV. And we have been working, as I mentioned, hand in hand, close. We have a joint work plan for our drugs and HIV group, which is more mature than the prisons and HIV group. And this shows some of the work that we are doing at country level, because we have grants for communities to strengthen communities. And these are some examples of the grants that we have provided. They're doing excellent work. Some of the work was actually presented for our World AIDS Day event. Again, I'm very proud of this work, and really it's we are really looking forward to continuing this relationship, and this is how it works, to give the leadership to the communities to address the situation at the country level. Next slide, please. Yeah, this is my last slide. What works, as I mentioned, meaningful collaboration with our community and the CSO partners. Advocacy, I can't say enough about that, really. You have to continue, even in countries where they're doing harm reduction. We can't stop, we can't be, we can't we have to be vigilant to make sure things are continuing. Legal reform, capacity building, high quality data, evidence to show what the problems are so that, countries do take action on it. And of course, building strong partnership with our civil society partners, community partners, law enforcement, drug control agencies, prison authorities, and of course our health and service providers. So and this is the picture of our drugs and our drug civil society group. And I think with that, I can thank you and give the floor back to Tim. Thank you for listening to me.
Thank you very much, both Simone and Fariba, for setting the scene with such rich presentations. I think we obviously need a week-long workshop. This is a really important area with so much good work going on, and I really like your introduction to this setting. And I'm sorry we have to try to rush people through a bit because we have a lot of speakers, but thank you so much. Now let us turn to some national responses. And first of all, I want to ask Excellency Dr Phalla Tia, who is the Vice Chair of the National AIDS Authority in Cambodia, to give us some remarks about their interventions. Dr. Tia.
So thank you very much for coming to this important meeting. I think we are honored to participate in the Global Prevention Coalition. And then I'd like to share our experience and what we have done so far addressing the legal barrier to scale up services for KP. So next slide. So I think you may have heard that Cambodia have a temple, and the most important king have a philosophy that it's around 800 years old. The philosophy where the body and mind suffering, which are serious and painful of the people, is not the people suffering, is the leaders. If the suffering is not anybody else suffering, and then this philosophy continue to be with the leader in our country. Okay, thank you. Good. Next slide. So
maybe if he can go off a video, it might help.
Okay, this is the slide about the KP. We have around 170,000 of KP in the country, and then you have a different prevalence. The most, the highest prevalence is among the injecting drug user. The MSM is 4%, EW is 3%, and then AG around 10%. But you cannot hear us? Can you hear us? Oh, okay. So I close down the haircut. Is it better now? Is it better now? So in here you have different key population, and also we have the barrier, like several issue affecting the people who inject drug, and then you have the crackdown. You have also the problem who detention in the facility. But anyway, in practice, the law, in the book and the law in practice could be different. For example, like like the law, the HIV/AIDS law 2002, regarding the testing. So it could be interpreted that it has some limitation for people younger than 18 years old, but actually people who are now on the field can hand the what we call HIV self-testing kit to the younger group. Next slide, please. Okay, so in here you have the access to prevention, and then the coverage. You have here the very high prevalent the coverage among the drug user, the transgender, and also the female sex worker. But we have around 30% only for the gay men. That's a big concern. And also, just to inform you, like we have, the data showing that the infection among drug user among the MSM is around 50% or more than 50%. Yeah? That's increasing remarkably. Okay, next slide. So to the issue of the enabling environment issue, we are fortunate to have the Global Fund support, and then we use the Global support to conduct the training on law and policy, and the support for HIV response at the subnational level. And the training has been conducted with health worker, the police, local authority. So up to now, from 2018 to 2020, around 800 people. You can see here about the policemen having what we call the lunch with the KP or civil society together, where they can talk openly, in the what we call the in this forum, and that is to support the community action approach, where the government, the local authority, the police, and then the KP work together. Okay, this is between 2018 and 2020. Okay, next slide, please. So, but the end line study of the project, 2018-2020, found that we have a important structural barrier, not allowing the what we call the key population to connect with the people who are on the outreach, who are on the field, not connecting to one another, and also not having enough financial support. Out of 70 operational districts, only KP network can operate only in seven operational districts. This is less than 10%, and also the function, how the key population is connected to the provincial level with local authority, the social worker is also disconnected also, and also more importantly is disconnected with the what we call technical board, policy board, where you have a different line ministry, and also disconnected with their representative in the country coordinating mechanism of the Global Fund in the country. So somehow they are underrepresented and under supported, and then not connected to one another level. Okay, next slide. So when we have the high level of commitment, we need to address not only the 995 but also the 10-10-10, and then this is we have some area related to the programmatic support. But if you look at the the highlight on the social enabler, 60% should be by the community-led organization, 80% by the community prevention by the community-led population, and 30% testing treatment by the community-led organization. These are the system support. These are system support, and we used to have more support on programmatic area, but the system support need to be well taken, and we intend to modify the situation where the programmatic support need to add more on system support. Next. So in here, you have from the beginning, you have in here in this row you have legal and legal provision. You have AIDS and drug law. You have 100% community program law, and you have anti-human trafficking, village and community safety policy, GBB, and fast-track city and social protection. These are the what we call you know, like provisional of the legal support to the key population. But in here, the training that I talked just now is part of the capacity building, linking the what we call the provider to the beneficiary. These are the program intervention. Okay, but right now we move from the program to the institutional strengthening, where we look for the decentralization. For example, like we have done the develop of a guideline on how to work with key population for integration of HIV/AIDS in the commune council, and that's you know, address more on the leadership, on the partnership, and investment for the whole country. And in 2019, we have you know, the Council of Ministers letter order to address six policy measure, including mostly the domestic support for the KP in improving their services. Okay, thank you. Next.
I think we have to move through a bit faster, Dr. Tia.
Yeah. Okay, so I'm about to finish. So we have the paradigm shift. We need to move from program-oriented to system-oriented, you know, transition to the sustainability. So right before we work in 12 provinces, now we narrow down to only 4 priority, and then this is our current global fund. Next. We use the opportunity to have a global fund, turn the global fund into the system support, you know, and let the program support, you know, by the Ministry of Health and then PEPFAR, things like that. So more importantly, addressing the system support of the country and linking the key population. Okay, next. So when we talk about the success, we need to have a policymaker, the provider, and then people, the beneficiary, join hands together, and then we develop only not only the hard skill but also the soft skill. In here you have the CCM, where you have a key population talking with the Secretary of State, with the development partner, you know, bringing the issue from the grassroots level. Next slide. So in here, you know, like the Prime Minister called for a national movement, which is a dynamic of stakeholder system. And then the triangle that I just said just now is should have a bi-directional communication, and also a dynamic of policy-led process where you have the population analysis, priority setting, budgeting, M&E, and things like that. Involvement of the key, the triangle, and the triangle lead to be connected from subnational level to national level. This is you know, the way the dynamic of stakeholder system work. Okay, next. Okay, so not only alone but also linking to the global fund as well. Next. Okay, so in here you have the key population, you know, including in the provincial AIDS committee, and then there is all support from the Ministry of Interior. There is no discrimination against key population and then people with AIDS. So here you have the governor, you know, talking, listening to the problem of the key population. Next. And here also, you know, we bring the appreciate the community mobilization, and we identify their problem, having the less, you know, like 7 out of 70 district level. That we need to have like sufficient financial investment and integration into national program. Next. So in here you have you have the governor also listening to the feedback, patient satisfaction feedback, and also community-led monitoring. So So, you know, like communication, bi-directional communication between KP and the governor. Okay, next. Okay. So whether we have, you know, like to discuss about the increase of, you know, like the PrEP from 1,000 to 10,000, we need to involve the key population, whether we need to shift from the user-initiated services to provider-initiated services. This is a slide that I took from Professor Salim Abdul Karim. And then this is also we need to discuss with the key population and whether we need to, you know, include into the social accountability framework. Next. The last slide, next. The last slide for us is to have the create supportive environment with social contracting. So meaning the government will give the money to high, you know, civil society to work with us, you know, to complement, you know, the gap within the global fund and within the PEPFAR project. So we have the different steps already identified how to make use of the domestic funding to support the what we call the gap that have been in the current funding. Thank you very much.
Thank you very much, Dr. Tia. So much going on in Cambodia. It's a really interesting program. And again, we should spend much more time hearing. Sorry, we had a bit of interference, but we could hear most of your presentation. Let's turn now to Jules Kim of Scarlet Alliance in Australia, who I'm sure will talk about some of the successes there as well as some of the ongoing challenges. Thank you, Jules.
Thanks, Tim. So my name is Jules Kim and I'm the Chief Executive Officer of Scarlet Alliance, which is the Australian Sex Workers Association. Next slide, please. Next slide again, please. So we were formed in 1989 and we are sex worker led at all levels. So even our governance, management, CEOs, everyone involved in Scarlet Alliance is a sex worker. This is really important to us as we, you know, value the importance of the community-led response and think that this is critical to the success of our interventions. Fortunately, we do have the faith in the government of doing that, and we are actually funded to do so. So we are funded through BBV, STI and HIV money, through to including for our advocacy on law reform, which I think is essential for the progress that we've made in recent years. So to understand the progress that's happened in recent years, it's also important to understand the environment of the laws for sex work in Australia. So we've got varied laws in each state and territory in Australia, and it varies between the different states and territories and also for the different types of sex work. So there's different laws for private sex work, for street-based sex work, for brothel-based sex work, and for all the different types, there's different laws, as well as different laws that for bloodborne viruses, STIs, including HIV and sex work. Unfortunately, there are contradictory laws between federal and state-based laws. So on the whole, we have federal laws that considers sex work to be a lawful occupation. However, some of our states still consider sex work to be criminalised. Next slide, please. So broadly speaking, we have three models: decriminalisation, licensing and criminalisation. And I think you could say that in most jurisdictions have some sort of a mix of these models. But you know, the impact of the different models was particularly evident when during COVID, when there were interventions federally that were available for sex workers. However, in states like South Australia and WA, where sex work was still criminalised, these were not accessible for the sex workers to have that financial aid that was accessible to sex workers in New South Wales and Northern Territory, where sex work is decriminalised. This is really pointed out the urgent need for a consistent decriminalised model of sex work regulation. Next slide, please. The positive benefit, I guess, one of the kind of sole positive benefits is that it does, the different models in the states and territories allows us to evidence the impact of the different models around Australia. on sex workers and basically on sex industry regulation. Where sex work is criminalised in jurisdictions as such as WA and South Australia, where it is still mostly criminalised, we still have practices where condoms are used as evidence. Sex workers do not have the right to remain silent and can be strip searched purely for being a sex worker. And in other states, there are laws that still make it unlawful to be a sex worker living with HIV, regardless of whether that there is any risk because you have an undetectable viral load, or regardless of whether protection is used, or in fact, if any non-protective, non-penetrative services have been conducted. Nonetheless, they are still considered unlawful in some states. Next slide, please. Similarly, in licensed frameworks, such as we have in a number of states still, such as Victoria and Queensland, there is compulsory registration and forced mandatory testing, which is an incredible burden on the health system. And in fact, Victoria recently changed their mandatory testing regime from 3 months, from 1 month, sorry, to 3 months. And the sexual health clinic, the public sexual health clinic, evidenced what a positive result that had, not just on attendance rates, but on testing rates and on STI rates, because it meant that people weren't just standing around for a meaningless certificate. It meant, in fact, if they did have an accident at work, they were actually able to get an appointment instead of having to stand in line for hours for appointment to just get a meaningless certificate. So that was great to have that. And fortunately, Victoria are now moving forward to repeal that forced medical testing. So unfortunately, there are a number of regulations still that still have a licensed framework that create massive barriers to justice, health and rights for sex workers. Next slide, please. Fortunately, we are seeing a positive momentum towards sex industry law reform. Now, New South Wales was the first place in the world to decriminalise sex work in 1995. And this was as a result of widespread police corruption in the sex industry. Now, it might not seem so, but I was actually old enough to be working in New South Wales at that time and have noticed the difference. And in fact, evidence has also demonstrated the strong benefits of decriminalisation, including on increased work health and safety, reduced corruption, increased access to health promotion, high rates of condom use, and low rates of HIV, and in fact, the virtual elimination of HIV among female sex workers. And this is something that stands in stark contrast to jurisdictions that continue to criminalise sex work. Unfortunately, since that time in 1995, sadly in 1995, not all forms of sex work were decriminalised, and street-based sex workers still do face criminalisation in New South Wales. And since then, progress has been very slow. And I think in large extent because sex workers, to a large extent, were battling anti-trafficking legislation during that time. And so that was actually a lot of our advocacy was consumed through that period. Yeah, understood. At that time with anti-trafficking legislation. However, since the evidence has continued to mount on the need and the benefits of decriminalisation, we have seen progress really building. And in 2018, the licence framework that exists in the Australian Capital Territory was removed registration and the licensing framework and the registration database that required sex workers to basically be marked for life and never be able to remove their name from a database, even after they die, was removed. And problematic laws that actually made it illegal for you to be a person living with HIV to actually be or see a sex worker were also repealed. And the government in the ACT has also committed to fully decriminalise sex work. More importantly, in November 2019, the long sex worker-led campaign in the Northern Territory led to the full decriminalisation of all forms of sex work in Northern Territory. Now, this is the first place in the world to do so and only the third jurisdiction in the world to have implemented a form of decriminalisation at that time. This was an incredibly positive example of government's willingness to work with sex workers to ensure reforms were as they were intended to be, and communicated effectively to the industry, community and government alike. Now, this meant that sex work was viewed as any other form of work. And this partnership with sex workers enabled the implementation of sex work decriminalisation effectively. And this included in having sensitivity training with police officers and other government departments. Now, sex worker organisations have been doing this all along and continue to do this, but there had been a scattershot approach. And the fact was, when it became decriminalised, it meant that everyone had to do it. And it wasn't just the people that actually, you know, were willing to work with sex workers or were extremely problematic that came to our attention. It was actually a system-wide approach that required everyone to have sensitivity training led by sex workers. And this, you know, it was really essential to break down the stigma and discrimination that still exists, even though you decriminalise sex work. And I think that that was the importance of maintaining that partnership through the change of the law.
We've lost your sound, Jules. I can't hear you.
Hi.
Back again, thank you.
Okay. Yeah. Okay, great. Sorry, I don't know how much of that you got, but another positive example was the fact that we were able to work in partnership with the Department of Health and the Work Health and Safety Regulator, with Scarlet Alliance and SWAP NT, the funded local NT sex worker organisation, to develop work health and safety guidelines that could actually positively frame workplace obligation for employees in the workplace, such as providing condoms and what to do when there's a condom breakage, and, you know, referees to sex worker friendly clinics in the area. Positively following these reforms, and fortunately we have also seen the Victorian government also announcing its intention to decriminalise sex work, and in fact this has already passed the lower house and is currently in the upper house, and the Victorian government have been positively working with sex workers again to make this happen. Next slide, please.
If you can start to wrap up, Jules.
Yeah, I'll just wrap up here. There's also been other reforms in other states also announcing intentions to move forward on this. And just to say, I think just my next few slides talk about the positive impacts of that. Now, that's no different to the other positive impacts that you've seen in other studies that have persistently shown that decriminalisation is the best practice model for the rights, health and safety of sex workers, results in low rates of BBVs and STIs, and is what sex workers have been calling for decades. Thank you.
Thank you very much, Jules Kim. A fascinating look. We have a really interesting natural experiment in Australia, and it'll be so critical to continue to collect the data to give us more evidence on the benefits of decriminalisation and the reduced harm that is associated with it. I think that's critical when we see in other parts of the world an increase in criminalisation and the Nordic model in criminalising clients. We really need to show that decriminalisation has the benefits, the best approach. Now we're going to hear more from the community. We have Phelister Abdalla of KESWA, and then Irena Ermolaeva of Kyrgyzstan. So Phelister, please take the floor.
Thank you very much. Hi everyone, I'm Phelister Abdalla from Kenya. I'm a Kenyan sex worker. I'm working with the Kenya Sex Workers Alliance as the national coordinator. I'm also the newly elected president for NSWP, the Global Network of Sex Workers Projects. So today I would share about the process that we have taken as a Kenyan movement when it comes to decriminalization, or the process we keep on taking all the time ever since we started. So in 2015, 2016, I think before I start, KESWA was formed in 2010 after the first African Sex Workers African Conference in Johannesburg. KESWA, Kenya was one of the countries that came out strongly to form the national movement group of sex workers. We work with male, female, and transgender sex workers. We work with sex workers living with HIV and sex workers who are using drugs also. So the reason why as sex workers in Kenya we came together is the fact that violence was really high among sex workers, and nobody was actually coming out to speak up about the violences that the Kenyan sex workers were actually facing. So in 2010, Dorothy Ogutu, Madenge, Penina Mwangi, and other sex workers leaders came out strongly to form the sex workers network here in Kenya. When we came out, we started speaking about the sex workers issues, how sex workers would like to be involved in different programs, why sex workers should get health services in time and everything, friendly health services, which really worked in time at that time. Police sensitization started, sex workers were trained as paralegal, sex workers started forming their own groups within their own counties so that they can be able to respond to the violences that they are facing at a local level. The situation got worse in 2015, 2016, and 2017. There were a lot, the violences were really increasing, and these violences were actually even murder cases. So in a span of maybe 1 week, we could have gotten 7 sex workers murdered, which means a sex worker is murdered each and every day, which became really challenging for us. So 2017, things got out of hand, and we decided to call for a national meeting, calling all the members so that they can be able to join in, so that we can talk about it and tell each other what is really happening in our country, and how can we be able to address to these violences? How can we stop the murders among the sex workers? So one of the things we did is we had a meeting of all our members who came in together in 2017. In this national meeting, we also invited legal partners, Katindi and Company, so that they can be able to advise us legally what are the legal actions that they think we can take. And we were weighing our options. That is when we had a negotiation they took us through of understanding the legal framework in Kenya. They told us about the penal code. They told us about the Sexual Offences Act that is the one that is used to criminalize sex work, and how we can penetrate within those systems. Why we wanted them to come in together with the sex workers is because we wanted to understand the legal framework in our own languages and within our own capacities. Sometimes we've seen how legal people can come with terminologies that we do not understand as a community. But in this time, we were sitting together in a room and we were like, we want to understand it in our own language. How do we break it down to our language so that we can be able to walk the steps together with them? That's when we were told about legalization, decriminalization, criminalization, the different types and everything. As Kenyan sex workers, that's when we decide, yes, we will be continuing to implement our advocacy programs. We shall be continuing to implement our health programs, but it is high time we start talking about decriminalization and what are the processes we intend to take. So this came from the legal team, and they said in Kenya, you can only change the law in 2 ways. One is through the parliament, convince the parliamentaries so that they can be able to put a document that can be presented in the parliament. Get more vote, a law is changed. If you don't get more vote, a law is not changed. We looked at it, it seemed to be a very expensive process for us, because when we look at our members of parliament who are representing us that we have nominated to sit at the parliament, these are the people who intend to want to go to meetings, conferences, then expensive for us. To an extent, we felt like that is a very expensive process that we cannot afford, and the results are not assured. after maybe now they are going to the elections, they decide, no, we don't want this anymore. So we decided to do, the other way is the public interest litigation. It's just do an open court process, bring your arguments, the court looks at it and they decide this is harmful to the Kenyan people and it needs to be changed. So we went with the public interest litigation way. But before we get to a public interest litigation, one of the things we realized is the fact that we needed to put our house in order. Why? We had to make sure that we had enough evidence, well-documented evidence to show that sex workers are facing violence, or we are facing violence within our own country. So what we decided is we decided to do, so we did a desk review to see if there are any researches that have been done in Kenya on sex workers and how we can use that data for us to put our documents or our legal strategy in order. Luckily, there was no that data that is ethically approved. So what we decided is we will collect what is available, the little that is available as a desk review. Then we actually decided to do our own sex workers-led research, a research that is done by the sex workers for the sex workers together with the sex workers. We took this to, we decided that it is going to be an ethically approved research, a research that was approved through KEMRI. KEMRI is an ethical body here in Kenya, well known. They approved. We wanted to do a research with adult sex workers only because as KESWA, we only work with adult sex workers, 18 years and above. When we took our presentation to them, they came back to us and said, this is a very good research you want to do. We can only give approval if you're also going to do an additional research for underage children who are in sex work. It was a bit crazy for us. We were not sure we really wanted to do that because we don't work with underage. It doesn't mean within the fields that we work in, there are no underages. They are everywhere within the streets where we operate. So we sat down and we told them about the maybe legal complications we were going to get by us deciding to do that research. They said they are the ethical body. They were going to give us technical team that was going to work with us doing that research. Katindi & Company also, that's a law firm that also worked with us during that research. It was a snowballing research. That means there is no way we could have forged the data. Whoever is coming to the research is given a card to give to someone else. So it was a research that was bringing its own people into it. So we also did the underage one with the support of KEMRI and Katindi & Company. Both research came out. So our fear is we actually thought that one of the results that was going to come out was going to say maybe adult sex workers are the ones who are influencing child sex work in Kenya. But the report actually came out clear because there were questions like, what is your fear? And the young sex workers will come out and say, our biggest fear is the adult sex workers. Because whenever they see us on the street, they chase us away. They do not want to see us here. They tell us to go back to school. So that came in very strong. Another thing, they were asked, what really pushed you into this as a child? Do you know you are a child? They all know they are children. Do you know that this is illegal? They know it is illegal. Another question that really came out is, have you ever been arrested? And they said, yes, we've been arrested, and without police knowing that they were actually underage and actually to an extent of taken to courts and charged. So these are some of the things that, results that really came out. Another thing that was really pushing them into doing this is peer pressure, seeing their other underage people who have nice things, they live a good life, and they would like to do the same, some supporting families and other things. We did these two researchers and we did a launch for both researchers. After that, we remember that the LGBT was also doing public interest litigation in Kenya. So we were keenly following those court processes so that we can be able to learn from the process. We can be able to borrow some of the things that they did. We can be able maybe to rectify some of the things that maybe were not done well. We also decided to be having meetings with GALC, which is the national movement of the LGBTQ in Kenya. so that they can be able to take us through the process. In this, then we divided our research into different forms. So we decided that we were going to have different strategies for it after we got the feedback from the research, the findings. So we decided that we are going to have a legal strategy. It's a strategy that is going to be drafted together with sex workers and the lawyers so that we can understand clearly what is within that legal strategy. We also decided to have a security strategy. Because when we have a public interest litigation, it means the faces of the sex workers are out. We are going to be outed. People are going to know who we are through the social media, through the media, through televisions and radios. So we decided that we want a security strategy so that we can be able to see where there's a security risk and we can be able to respond to it. This is the reason why the security strategy came in, or in case of any attacks, then that's where we came in. Another thing is we decided to have actually a communication strategy, because when you are having such a process, it means communications are coming from different areas. Communication strategy was actually for us to make sure that as sex workers, we are actually sending the same message to people. We are telling people this is what we want. This is the message we are sending out. This is the person who will read a press statement. Even if they go to the grassroots, they will still hear the same message that is coming from the sex workers. It is the same one from the national movement. It is the same one from the groups. It is the same one from a sex worker who is in a brothel or a street. That is the reason why we really needed a communication. Okay. So I think with this, this is where we were. Then COVID came in, but all the strategies have been drafted and are ready. So one of the things we are looking at next year to see how are we going to courts and other processes. Now we are just collecting evidences from the sex workers groups in different parts of the country, just to make sure that we have enough tangible evidence and we are well prepared so that we can be able to submit our case to courts. And this is also because the Kenyan courts were also shut down. They were only doing online urgent cases, and apparently ours was not urgent. But this is the process that we intend to take starting next year. Thank you.
Thank you, Phelister. Amazing empowerment. The community is empowered and has real power there, and showing what you can do collectively. Really, thank you so much. We must move. I'm sorry I keep just telling people to round up, but there's so much to say and listen to. Perhaps we hear now from Irena, who is going to speak in Russian. So please select your language at the bottom. Irena. Yes, please go ahead.
Всем добрый день. Меня слышно, я надеюсь. Меня зовут Ирена Ермолаева. Я представляю организацию Asteria из Кыргызстана. Наша организация – это сообщество женщин, употребляющих наркотики. Можно следующий слайд? Меня слышно, нет?
Да, слышно, Ирина.
Следующий слайд, можно? Спасибо большое. Мы члены Input и национальной сети снижения вреда. В 2007 году в Кыргызстане была декриминализована статья Уголовного кодекса за употребление наркотиков. Но при этом хранение у нас остается до сих пор. За небольшие дозы административные наказания, за большие, крупные и особо крупные уголовные наказания. 3 раза была реформа в Кыргызстане в отношении наркополитики, но до сих пор все еще остается группа наркопотребителей в самом худшем положении в отношении дискриминации, карательных законов. Дальше можно, пожалуйста. Следующий слайд, пожалуйста. Сейчас я немножко скажу, что несмотря на то, что наркопотребители находятся, как и в других странах постсоветского пространства, находятся в двойной дискриминационной, на уровне законов, двойная дискриминационная норма, так сказать. Это мы считаемся и, то есть преступники в уголовном законодательстве, даже за хранение для личного употребления. Это тоже является преступлением, несмотря на то, что общественному вреду это по сути ничего не несет, а мой личный вред, который я сама себе наношу, это мое право человека на здоровье, да, и так далее. Тем не менее, представлены наркопотребители в рабочих группах по разработке национальных программ, стратегий, планов, действий по преодолению ВИЧ, по достижению гендерного равенства, по преодолению правовых барьеров для ключевых групп, по реализации государственных социальных заказов для Министерства труда, социального развития и Департамента пробации. Дальше можно, пожалуйста. То есть наркопотребители, организации и сообществ. Следующий слайд. Мы, получается, где-то выступаем инициаторами, где-то участниками полноценными в данных рабочих группах на уровне приказов Министерства здравоохранения, государственных приказов. В разработке законов о пробации, о туберкулезе, то есть получается все, что связано с общественным здравоохранением, все, что связано с социальными вопросами, о гендерном равенстве и о насилии над женщинами, это все имеет отношение у нас к Министерству социального труда и защиты. Доступ у нас на совместную работу имеется, да, наработки, успехи также имеются. Вот. Различные приказы были подготовлены. Например, у нас в Кыргызстане есть клинический протокол. Следующий слайд можно листать. Клинический протокол медицинский для врачей, акушеров, гинекологов, который позволяет выдачу метадонов для беременных женщин, которые употребляют наркотики или являются участниками метадоновой программы, доставлять метадон в родильные дома. Также у нас создан клинический протокол. Астерия с 2012 года мы адвокатировали продвижение клинического протокола. Это для гинекологов о предоставлении гинекологической помощи для женщин, которые употребляют психоактивные вещества. Также есть в стране внутренние правила приписки населения к поликлиникам государственным. И в 2015 году мы, получается, добились того, что доступ был обеспечен для клиентов программ снижения вреда. Мы работали когда мы вообще работаем над адвокационными законами, мы стараемся, где это возможно, не говорить только за женщин, употребляющих наркотики, чтобы, пользуясь случаем, доступ был обеспечен и другим ключевым группам. С правилами приписки населения к поликлиникам так и получилось, что мы предлагали, разрабатывали стратегию, которая означала, что у многих людей нет паспортов, документов, удостоверяющих личность среди наших групп клиентов. И доступ к больницам уже отсутствовал. По справкам от неправительственных организаций, у которых есть какие-то приюты или шелтеры, у Астерии у нас есть шелтер, где мы принимаем женщины, которые в трудной жизненной ситуации находятся, или жертвы домашнего и гендерного насилия, шелтер, убежище. Ну, то есть и мы можем давать справку, на основании которой они получают доступ к поликлиникам. Дальше, пожалуйста, можно? Также получается, что я, как от нашей организации женщин, употребляющих наркотики, получается, была членом общественного наблюдательного совета несколько лет при государственной службе по контролю за наркотиками. Также активисты сообщества были в наблюдательном совете при службе исполнения наказания. Ну, то есть те сферы, которые наиболее, так скажем, относятся к наркопотребителям. Это тюрьмы, это пробация, это наркология и милиция. Но вот здесь хотелось бы отметить, что наш фонд в 2019 году мы получали государственный социальный заказ на наш шелтер. Это для женщин, которые находились и находятся в конфликте с законом, то есть клиенты пробации, клиентки. И получается, но до сих пор остается у нас в стране, что государственный социальный заказ – это, знаете, неполноценное финансирование. Это лишь такой, скажем, маленький довесок, который дает, откровенно говоря, резюме организации, плюс, ну и как бы какие-то возможности на укрепление сотрудничества с государством. Также матчинг-фонд. Наша страна получила это дополнительное финансирование по глобальному фонду, где проводится большая работа на преодоление правовых барьеров. Дальше можно, пожалуйста? Следующий слайд.
If you can round up.
Дальше,
Yes, thank you.
Да, дальше слайд. Там фотографии. Их можно потом. Ну, то есть в отношении правовых барьеров я пока говорила, постаралась вещи какие-то отметить. Все сложно. Вызовы на 2020 год, что у нас сейчас, как у сообщества потребителей наркотиков, затруднен доступ к группам, которые пересматривают антинаркотическую национальную программу, которые пересматривают закон о наркотиках. Также растет статистика задержания милиции, клиентов метадоновой программы и наркопотребителей. То есть какая-то нездоровая ситуация. К чему готовимся? Вот от 1 декабря у нас принято уже 3-й этап наркополитики в Кыргызстане. Это, опять же, кардинально 3-й вид кодексов уголовных и правонарушения. Есть плюсы, есть минусы, но как оно будет, покажет только практика. Мы постараемся проводить мониторинг исполнения этих кодексов, как они влияют на судьбы жизни наркопотребителей в следующем году. Проверка НКО. Также в этом году в Кыргызстане, получается, в закон внесли поправки. И как оно отразится, будет ли это модель российской, как в России, будет ли такая же модель, то есть прессинга и карательного, так скажем, ракурса, там, дискурса в отношении НПО. либо не будет, то есть, опять же, мы увидим в следующем году. И третье, это, ну, вы можете перелистнуть, там просто более подробно, и на этом все. Следующий слайд. Рецептурная выдача опиоидной...
I think we're going to have to round it up, I'm afraid, now.
Все хорошо, да. То есть рецептурная выдача опиоидной поддерживающей терапии бупренорфина метадона через аптечную сеть. Спасибо большое. Все, спасибо.
Thank you very much, Irena, for some really concrete actions to support the community and to challenge some of the alienation and marginalization to be a more inclusive society. It's really wonderful to see these activities that Asteria has put forward. Thank you. All the presentations have been really excellent, and we've run way over time. We're going to have to skip the discussion. I would encourage everyone to put your comments into the chat or the Q&A, but we're going to go straight now to some commentary from observers who've listened to all of the presentations and would like to make a few closing remarks. I'll go to Ruth Morgan-Thomas first from NSWP.
Hello, and thank you to all of those people that are presented to us. You've heard some particularly harrowing tales from community representatives about how our communities are treated. And I want to thank Phelister and Jules and Irena for highlighting the realities of our communities. Just to put some of it into a global perspective, drawing from the countries for my community, sex workers, 45 to 75% of adult female sex workers report experiencing violence. That's quite a phenomenal statistic. And much of it comes from law enforcement agencies and actors who are meant to protect us. So I think highlighting that needs to be as strong as highlighting HIV and infections. And as of 2021, UNAIDS reported that female sex workers are 26 times at greater risk of acquiring HIV than other adult women. Oh, sorry, my cat's coming to visit us. And in 2020, sex workers represented 11%, and the sexual partners of all key populations represented 20% of all new infections. Now, these are startling statistics. Modeling done by the Lancet special issue on HIV and sex work, though, estimated that we could prevent 33 to 46% of new infections among sex workers and their clients if we decriminalize sex workers. So when we talk about structural barriers and we acknowledge how difficult it is to address them, the benefits, the gains that we can have from working towards decriminalization, but never ever losing sight of that final goal for decriminalization. Because criminalization and repressive policing policies are associated with heightened risk of sexual and physical violence, HIV, STI infections, and barriers to condom use for sex workers. HIV prevalence among sex workers in sub-Saharan Africa in countries where sex work is criminalized is 39%. While in the countries that have partially legalized sex work, it is 12% prevalence amongst our community. And as Tim said at the beginning, we face the risks are exacerbated for multiple forms of oppression due to gender identity, sexual orientation, racial or ethnic backgrounds, and drug use. And the HIV response has been less successful in countries that criminalize sex work, same-sex sex, and drug use. Sex work criminalization was associated with 10% lower knowledge of HIV status and 6% lower viral suppression among sex workers. that criminalization amongst same-sex was associated with 11% lower knowledge of HIV status and 8% lower viral suppression, while among drug users, it was 14% lower across both of those. And yet, when you add those together for members of my community, who are male sex workers servicing male clients and sex workers who use drugs, it went up to 18 to 24% less. Now, these are really important statistics that we need to hold at the back of our mind as we try and struggle with how do we take the steps that will enable and empower communities to protect themselves. Thanks, Tim.
Thank you very much, Ruth, for bringing those really critical statistics to us, and also the issue of violence really, in a way, superseding that of HIV infection. If people do not have physical safety and are subject to violence, then that has to be the priority that we all face and try to tackle. Thank you so much. Let me turn to Alexandrina Iovita of the Global Fund for some closing remarks. Alexandrina.
Thank you, Tim, and thanks to everyone for this very compelling reflections from communities on the ground, and thanks to Ruth for bringing it into a global context. We've heard about the fact that we have commitments in the political declaration, in the global AIDS strategy, we have societal enabler targets, so we have an opportunity here. We've heard about the global partnership and how the global partnership can serve as a platform for action. It's important that we also mobilize the resources that we need for such community-led responses to human rights-related barriers, to structural barriers. Global Fund does have a commitment. It has a key performance indicator committing to invest 3% of its HIV allocation into programs to reduce human rights-related barriers. So do use it, do hold us accountable. Use the country dialogues in order to meaningfully engage communities, to develop funding requests, but actually do invest in programs to address structural barriers. Use the technical briefs and the applicant guidance, some of that I've shared in the chat. Use the support from technical partners in order to make it happen. We also provide technical assistance to communities to meaningfully engage. We're also working internally in trying to get our own staff to understand better the structural barriers that key populations face. We're working together with the key population networks in order to develop such learning content for Global Fund staff. It's through working together. It's through taking the opportunity of such platforms as a global partnership. It's through using the investments in order to deliver results that we can have a meaningful impact on reducing structural barriers, on achieving the societal enabler targets, and on ensuring that HIV prevention actually reaches all those that need it. Thank you.
Thank you, Alexandrina. Very succinct words, excellent. And finally, we're going a little bit over time, but we'll come to Trista Bingham from CDC for your closing remarks.
Hi, thanks. Greetings, everyone. Trista Bingham from CDC, and I will be sharing some updates on behalf of the broader PEPFAR family at headquarters in Washington, D.C. in the U.S. So key populations are among PEPFAR's core program and policy priorities going forward through PEPFAR's draft COP22 guidance, and in alignment with the new global AIDS strategy, we will be deepening efforts to support key populations through an increased focus on enabling environments that support KP-centered differentiated HIV services. To this end, PEPFAR is prioritizing building KP competency of PEPFAR service providers, as well as highlighting the need to build leadership and service delivery capacities of KP-led civil society organizations themselves. As referenced in the equity section of the draft PEPFAR COP22 guidance, the UNAIDS 2021 to 2026 Global AIDS Strategy recognizes that inequalities are central to the global delays and gaps in accomplishing the goals of the HIV epidemic control. Therefore, addressing these inequalities will be essential to a success. Prominent inequalities that impact global and PEPFAR progress are observed among children, adolescent girls, and young women, and of course among key populations. While PEPFAR has already dedicated attention and funding for HIV services for these groups, these investments have not been of sufficient scale and impact to achieve intended outcomes. We who work with key populations in PEPFAR often remind colleagues that 65% of all new infections in 2020 worldwide occurred among key populations and their sex partners. We need to do better to prevent these HIV infections. In using an equity lens to achieve epidemic control for the long term, we must recognize that public resources are inherently constrained, and those limited funds have to support the most vulnerable and disadvantaged. We must explicitly ensure that donor and public spending is targeted preferentially where the needs are the greatest. PEPFAR country teams and national programs must take deliberate and specific action to identify and address gaps in coverage for testing, treatment, and viral load suppression amongst key populations that are not meeting the 95-95-95 benchmarks. In many of our supported countries, these gaps are among key populations. We here all know that members of key populations face risks of HIV acquisition, many times higher than the general population. To close those gaps for key populations, the new PEPFAR COP22 guidance has updated program requirements to help achieve equity and impact for key populations. Implementation of COP22 guidance will hopefully facilitate a more direct pathway to equitable services for all beneficiaries of PEPFAR dollars, but most notably key populations. Thank you so much.
Thank you, Trista. And that brings us to the end of our presentations. I want to thank all the presenters who've really delivered such amazing presentations and really shown us the wealth of experience and interventions and support and community-led responses that are really making a difference. And I've run over a little bit, but because really I think we should treat this session as an introduction, a springboard that we need to continue to focus on addressing the structural barriers. This is the hard yards. These are the issues that really need to continue to be addressed with advocacy and energy. So thank you again, everyone. I think we've seen how addressing the structural barriers really enables community leadership, and communities are really driving this dialogue for change. Through their empowerment and their engagement and inclusion, we're really realizing the human rights of everybody, and people who have been left behind. We really need to have more inclusive societies, more equitable societies. We're talking about social justice here, and the structural barriers are the issues that are denying people their rights and denying social justice. So I would suggest that we need to come back to this and have further discussions about this. We have to stop now, but again, thank you to all the presenters and all of the comments in the chat. Please save the chat. We have many useful resources that have been presented and links there. And we look forward to a safe and peaceful end of the year, and continued our work on our advocacy next year and beyond. Thank you so much, everyone.